الباحث ابراهيم عبد العزيز ابراهيم الحمام، وبحثه مقدم في قسم الصيدلة عن نظريات ارسطو من او في عصر التطور التكنولوجي. وهو بقى هيفهمنا اكتر حول البحث بتاعه، وهيترأس لجنة المناقشة مع الدكتور هيثم قشط. اتفضل يا دكتور. دكتور ابراهيم حضرتك معايا؟ الو.
University degree and I have intermediate university degree in the field of pharmacy from Health Sciences College in Hufuf. Currently, I'm working in Al Jabr Hospital Pharmacy. I have some courses. I finished the course in health insurance from the Rope platform and the course in modern teaching style from Arabian Gulf for training and the course in educational guidance skills from Arab Gulf for training. This research paper is dedicated to my parents, colleague, and my beloved country. The preface of the research paper is this actually research paper is done in accordance with the Kingdom Vision 2030 and as a humble participation in the field of economics. This is the content of the research paper, and we will review one by one. This is the research plan. The research have been done to have a broad view in the field of health economics, from the history to the current time to the digital platforms time. So we will take the broad view from the beginning till the digital platforms. Introduction, research problem. Actually, we have absence of a complete guide for the workers in the field. So we have many books, many references, but each reference covers a part of the field. Actually, during my search, I did not find a reference that fully covered all the parts in the health economics field. So I try to have an overview in the field. This is the research importance. This paper is done to have a comprehensive review in the field of health economics. And I try to link the worker with the market in the market field. Research questions. We'll try to answer these questions. What is the relation of Aristotle with health economics? What is economics? Who is the father of modern economics? And what is health economics? And what is the role of Kenneth Arrow? What is the Grossman model? How illness can be measured? And what is the relation of Hammurabi with insurance? How treatment profits can be managed? And what is Nafis? Chapter 1, Introduction. The word economics comes from the ancient Greek oikonomia, and oikonomia means household. Originally, the word oikonomia denotes two parts, to the household and the labors. The word oikos means household. Aristotle's relation is that he speaks about the science of using slaves. نتكلم شوية بالعربي زي ما الدكتور طلب بس عشان نوضح. طبعا كلمة الايكونومكس جات من أصل إغريقي ومعناها الأدوات المنزلية. طبعا علاقة أرسطو بالموضوع إنه تكلم عن العبيد. كان في كتاب للعبيد اتكلم عنه أرسطو في العصر الإغريقي، وحنشوف قدام إن شاء الله علاقة أرسطو برضو بالاقتصاديات الصحة. Definition of
تمام.
economics:
كمل. تمام.
we have limited resources. So how we can manage these resources in the best way, this is the role of economics. So economics' main role is to manage the limited resources. Types of economics: economics divided into microeconomics and macroeconomics. Microeconomics deals with individual units or individual decision-making units. These units can be a person, can be an organization or a government agency. And economics deals with macroeconomics. Macroeconomics deals with the overall economy on national and international levels. So macroeconomics use the data to form the models. Development of world economics. First economic study was done in the ancient Greece, and this study was about the influence of population growth or the relation of population growth with economy. Four civilizations plays a major role in the development of economy. Actually, these civilizations in the Bronze Age, about 4,000 years to 2,500 years before Christ. These civilizations are the Babylon and the Sumer and the Indus River Valley and the Yangtze River in China and the Nile Valley in Egypt. This is the Code of Hammurabi, and this is believed one of the early codes that document the economics in the history. Who was the father of economics and what was his findings? Actually, in the modern era, Adam Smith is a Scottish philosopher and economist, and he is believed as one of the most important economists in the current time. His first study was about, it was an article titled An Inquiry into the Nature and Causes of the Wealth of Nations. Actually, this was one of the first books to introduce economics in the world. Smith and many economists like David Hume and Alfred Marshall, actually they gave birth to the modern economics. To manage the time, as I mentioned, I will try to concentrate in the main points. Health economics, this is chapter 2, health economics. Health economics, it's actually describe the various factors that converge to influence the healthcare industry cost and spending. So health economics as a field, it involves the study of individuals, providers, insurers, government agencies, and the role of each of these in the field of health economics. This is actually the relation again of Aristotle with the research. So Aristotle, actually he is an ancient Greek thinker, and he talked about the relation between farmers and doctors in production and exchange. now I will speak about the modern health economics. Kenneth Arrow is actually, we can say, the father of modern health economics. Kenneth Arrow actually published an article known as Uncertainty and the Welfare Economics of Medical Care. This article published in the American Economic Review, and this paper is one of the most widely cited articles in this field. And actually, this article continues to be one of the most cited articles in the current time. And this article citations between 1991 and 2000 actually 5 times more than the era between 1963 and 1972. This is due to 2 reasons. The first is its intellectual elegance and insight. The second is that it touched the core feature of public health policy debates. Actually, this is now I will speak about the health economics key areas. We have 6 main areas, and this is actually as an example. The first area is the spending growth, then the role of the patient, the role of the provider, insurance, benefit design, and the payment reform. Spending growth, healthcare expenses have been rising in this time in both absolute and relative terms. And in this time, in the technology time, this is actually will affect the cost. The role of the patient can choose the service, and this is the role of the patient, we can say the demand part. This is the demand part. So patient represent the demand part, and the provider represent the supply part. The role of the provider and healthcare production. As I mentioned, the patient represent the demand part, the provider represent the supply part. So the provider can choose the service, can choose the treatment, can choose the lab test, can choose the X-ray machines. So this, of course, will has its great impact, its great effect in the field. Insurance, and this is one of the modern things that recently have been developed. Benefit design, and actually benefit design is involved with the package. And how can package affect these things? The payment reform, this is how we can manage the payment. So we can manage the payment through episode-based payment or direct fee for the service. Chapter 3, Grossman model. This is actually one of the most important model in the current time, and it has a relation between health and well-being. So Grossman model discuss the relation of health with well-being. So health, as it defined by the World Health Organization, is a state of complete physical, mental, and social well-being, and not merely absence of disease or infirmity, so that each citizen can lead a socially and economically productive life. Dimensions of health. Health has physical, social, intellectual, emotional, and spiritual dimensions. This is the definition of the second component of Grossman model, the national wellness. The wellness. Wellness, as it was defined by the National Wellness Institute, is an active process through which people become aware of and make a choice toward a more successful existence. Component of well-being. Well-being has 2 main components. The first is subjective component and the second is the objective. These are the subjective components, which are subsequently divided into standard of living and level of living. The standard of living include the income, occupation, housing, sanitation, nutrition, health, education, recreation, and the other services, and the level of living health, living food, education, occupation, working, housing, social security, clothing, and recreation. This is the objective. And objective include the quality of life, happiness, satisfaction, gratification, health, marriage, family, work, and the financial part. The demand for and invest on health or the Grossman model, as I mentioned, a Grossman model discussed the relation of health with well-being. And also it discussed the role of many variables like the age, education, health states, and income, and their role in the production of health. This is a brief introduction about Michael Grossman. Michael Grossman defined health as both consumption and the production good. So Michael Grossman linked the production and the consumption. So he considered that the individual is a consumer and a provider at the same time. Criticism of Grossman's model. Actually, this model has some limitation. These are some of the limitation. Grossman assumes health is a constant life investment, but this does not happen generally. He also ignores the importance of insurance. And Grossman also assumes perfect information on the part of consumers. And this is actually does not happen in the. Also, Grossman does not take into consideration the random occurrence of illness. Chapter 4, disease measures. In this chapter, I will discuss the how we can measure the diseases, and we have two main internationally well-known measures, the QALYs and the DALYs. Health intervention aims to reduce the burden of disease and increase the quality of life of populations. And in order to achieve this, we need to measure the burden of disease. In order to measure the burden of the diseases, we use two main measures. This is the first one, the DALY, or the Disability Adjusted Life Years. Actually, this is proposed by the World Bank and the World Health Organizations. And actually, in this measure, we consider death as 1 and the perfect health as 0. This is opposite to the other measure, which is QALY. In the other measure, we consider that the perfect health is 1 and death is 0. So this is the functions of DALYs. DALYs are used to indicate the impact of diseases on a population. They are used to measure the difference between the cured situation and the ideal situation. DALYs used for a number of diseases that can be added together to indicate the total burden of a disease. DALYs is a summary metric of health of a population. Health gap of DALY represents the state of population health compared to normative goal. The goal is for individuals to live the standard life expectancy in full health. This is the other measure, which is QALY, or the Quality Adjusted Life Year. This measure developed in Britain and forms the basis of the work of the NICE, the National Institute for Health and Care Excellence. And actually, it has been used in many other countries, not only in Britain. This measure actually is used widely in the field of health economics evaluation as a means of quantifying the health of effective medical intervention or prevention program, and ultimately to help payers allocate healthcare resources. As I mentioned before, a year of a perfect health considered to be 1, while the death considered to be 0. Functions of quality adjusted life years. Quality adjusted life years, or QALYs, are used to quantify the effectiveness of a new treatment and to compare the health benefit of a new treatment and to evaluate the cost effectiveness of treatment. As a conclusion, QALYs and DILYs are tools providing a single measure of mortality and morbidity. Mortality is the يعطيك العافية. So mortality represents the death and morbidity represents the disease rate. Chapter 5, Health Economics Models and Insurance. This is the Bismarck model, and actually this is the first insurance model in the modern era. And this is named after the German Chancellor Otto von Bismarck. The main characteristics of this model is that providers and payers are private, and many countries applied this model, like France, Belgium, Netherlands, and Germany, the founder, of course. The second model is the Beveridge model, and it's named after William Beveridge. In Britain, the main characteristics of this model is that healthcare is provided and financed by the state through tax payment, no medical bills. Treatment is a public service. This have been applied in Great Britain, of course, the founder, Italy, Spain, Cuba. This is the national health insurance model, and this is the one of the modern models. This system has elements of both Beveridge and Bismarck, so it merges both of the previous models. No need for marketing, no need for financial motivation to allocate claims, and no need for no profit. So providers are private, payer is a state-run insurance program, national insurance collected monthly, and can control cost by limiting the medical service payment and making patient wait to be treated. This has been applied in Canada and some countries like Taiwan and South Korea. The out-of-pocket model, this is the poor countries model. And perhaps 40 of the world's 200 countries have established healthcare systems. So this is for the poor countries. So in this model, rich people get the care. Most medical care is paid for the patient. No insurance or government plan. This have been applied in rural regions of Africa, India, Bangladesh, China, and some countries in South America. Health insurance, actually, health insurance is a type of insurance coverage that typically pays for medical, surgical, prescription, drug, and sometimes dental expenses. Health insurance policy is a contract between the provider of the service and the patient. How health insurance works? Actually, you know that in Breathe, sometimes someone can have a major disease, so he will pay too much, and sometimes he will face nothing, so he will pay nothing. So this is how the idea of health insurance work. The types of health insurance, we have the health maintenance organization, preferred provider organizations, exclusive provider organizations, and the point of service. This is the Bismarck's model, as I mentioned before, this is the first insurance system in the world. It started in Germany. Insurance in KSA, in my beloved country, Council of Health Insurance started 1999. Health insurance actually started at 2005, and the health insurance for Saudi citizens working in private sectors start 2008. Chapter 6, the RCM, or the revenue cycle management. This is how we can get the payment from the patients. So revenue cycle management, a brief, is a full cycle. It starts from patient acceptance till patient billing. Benefit of healthcare RCM, actually it closes the gap between the patient and the healthcare side. Well-designed proper RCM system streamlined the billing and collection cycles by accurately pre-registering, making appointments for, and scheduling patient, collecting existing balances, processing payments, and questioning insurers when they deny claims. I will skip some slides concentrating on the main points to manage the time, so this is why I apologize. This is the main RCM components. RCM start with patient acceptance and registration, then we go to the treatment and the documentation, coding and grouping. We finish the coding because the payment and the billing process depend on the code. So if there is anything with the code, there will be a rejection in the claim. Challenges associated with the RCM, coding precisely. As I mentioned, if there is anything with the code, the claim will be, there will be a rejection in the claim. Also meeting the compliance standard, credentialing providers, applying data analytics, and incorporating paper charts. Chapter 7, challenges in health and economics. Chapter 7, challenges in health and economics. As you know, we face some challenges like the coronavirus. We have some emerging diseases. This is some of the factors that lead to emerging diseases. So this is the international trade and commerce, change in human demographics, and lack of public health service and antibiotic resistance. This is the top 8 emerging diseases categorized by the WHO. Ebola, Marburg, MERS, SARS, Nipah, and the Rift Valley fever. This is coronavirus. You know, this is the crisis of our time. This is the last chapter, chapter 8, the digital platforms and Nafis, or the Saudi experience as a model. So this is Nafis, or the digital platform. And actually, Nafis is a national platform for health and insurance exchange service launched by the Cooperative Health Insurance Council and National Center for Health Information, led by the Sahati company. Nafis actually component, it includes the insurance service and the clinical service. Nafis link both the insurers with the providers. This is some of the Nafis services. Nafis gave the management of the claims, fraud management, eligibility management, radiology images and result, clinical summaries, visits, coded lab orders, referrals, vaccinations. Abstract. Shall I mention the abstract in Arabic, Dr. Muhammad?
Yes.
باختصار طبعا